Welcome to CLP number 801.
It is one of the dream come true to introduce Sir Dcruz sir. But before I introduce Dr. Anil Dcruz to you people, and I don't have anything in my hand, it will all come from the heart. But before I introduce Sir, I must introduce you to this forum. This forum is so scientifically stimulated and close-knit, sir. Every time when I speak something here, I feel, it is like I go out euphoric. So, thank you all of you for continuously having these scientific forums where we learn out of you. And, Chauhan sir, you are doing a wonderful job and continue doing that. Now, introducing Dcruz sir. There is, and I say this with 100% conviction that he is a legend. He is a legend in head and neck oncology. I can talk about he has 33 years of experience, he has done so many publications, he has given so many talks, but bottom line is that he is a legend and he has taught all of us head and neck oncology, हाथ पकड़ के हमको सिखाया है, and with the great humbleness that you will again go back next day morning to him and sir ये समझ में नहीं आ रहा है, ये बताओ ना sir. Last 2 days back, Times of India, I'm sure many of you must be reading, उसमें front page पे top में only newsmakers of the world का आता है snippets. And I was surprisingly amazed that Dcruz sir's photo was there in the front page of Times of India. And I must say this with a great pride. He's the first Indian to be selected or elected president of UICC. This is Union Internationale Cancer Control. 1933 this foundation was there. 171 countries are the members. 171 countries, more than 2,000 members, and we have our first Indian who is the president of the next 2 years. I mean, this is very wonderful. In 2015, I remember again, and I was part of the person who was listening to his mesmerizing talk. I must say he's a gifted orator. I like myself to be called as a good orator, but if I am 1 on 10, he would be 9.5 out of 10. He's a very gifted orator and excellent person. You learn every time you listen to him. 2015, there is ASCO, American Society of Clinical Oncology. Now this is the most coveted conference across the world. 60,000 oncologists across the world assemble in the city of Chicago, and there is a deliberation on that. Every pharmaceutical company will wait for their paper to be presented in ASCO. Sir was given the plenary session on oral cancer, and the next month it was published in New England Journal of Medicine, and I think Sir was the first one to be given plenary session in ASCO also, sir. And I can go on and on. Right now, Sir is Director of Surgical Oncology in Apollo Group of Hospitals. He visits Delhi. He is based out of Mumbai and Chennai, if I am not wrong.
Delhi and Mumbai.
Delhi and Mumbai, the main. He has more than 500 plus publications, and you have to listen to him to say what I am trying to say. I will go on and on. I'll stop now because the time would do. Thank you so much, sir, and thank you, Chauhan sir and Poddar sir, for giving me this opportunity to introduce sir. Thank you so much.
Am I heard at the back?
Yes, sir.
Yes, sir. Anyway, thanks Ameesh for a very warm introduction. I always feel when I get an introduction like this, I hope my wife was in the audience. She treat me very kindly for the next few weeks. But Ameesh and me go a long way back. He was with us at the Tata Memorial Hospital till he decided to come to Delhi, and I'm proud of what you have achieved here. In fact, let me start by telling you that I'm a Delhi boy. I was born in Delhi. I grew up in Delhi. I still have a home in Delhi. and that's the reason why I'm back in Delhi. Hopefully, now between Mumbai and Delhi, but hopefully I'm looking at shifting slowly, with the love and affection you are showing to Delhi finally permanently. Dr. Chauhan, thank you so much for having me on this program, and I've met so many of you all in the last 15-20 minutes, and I'm really delighted to be here. I gather that we are a mixed crowd. We have people in general practice, orthopedics, neurosurgeons, pediatrics, so I've got ENT specialists as well. So I'm going to try to keep my talk very brief, very simple, and try to give a message to each one of you all. I've entitled it, Cancer, the Growing Epidemic, the Way Forward. I bring you greetings from Apollo, which is my new home. I was 33 years at the Tata Memorial Hospital. I rose up the ranks, and for the last decade I was the director of that hospital, and I finished as director in 2018 when I opted to join the Apollo group. The change that I've tried to do at the Apollo Hospital is bring in organ-specific work. That means everybody specializes in one part of the body. So I'm a general surgeon by training, and I can do everything, but I only do head, face, neck surgery. And the second change we are trying to bring across the group is to do something called evidence-based. So it should be all evidence-based, multidisciplinary clinics, and the patient gets the best treatment. So cancer we all are aware of. It's called the growing epidemic because if you look at WHO global cancer statistics, 1 in 5 men and 1 in 6 women will develop cancer in their lifetime. If you look at the figures from 2012, 12 million had cancer. This is global data. In 2012, 18 million in 2018, and look at the jump to 2020, 19.3 million. Lung cancer is the most common cancer globally, 11.6%, and 18% of mortality is caused because of lung cancer. In our country, it's a little different, and we see a lot of head and neck cancers. About a third of cancers in our country are head and neck cancers. Now these figures are global, but WHO predicts over the next 2 decades. Today, 2/3 of cancers are in the developed world, 1/3 in the developing world. But WHO predicts that the pendulum will swing, and 2/3 of cancers will be in the developing world, and we, with a population of 1.3 billion, will have a large number of cancer cases, and that's why I call it the growing epidemic. And here are the WHO predictions to show you that the more developed countries have kind of plateaued in the incidence of cancer. Now, this is recent data from our ICMR group, our National Cancer Control Program, 2020. These rising figures are reflected in our data as well. So the trends in cancer incidence have shown an increase in all sites and both sexes in our country. The 5 leading sites of cancer in our country are breast, lung, mouth, cervix, and tongue. If you look at these 5, lung, mouth, cervix, uteri, and tongue are all preventable cancers. And I'll just talk a little about them subsequently. And we are primarily seeing an increased incidence because we've started to live longer. At independence, the average lifespan of an average Indian was 47 years. It's gone up to 72. We have rapid modernization and a changing lifestyle, and all these cause an increase in incidence. It's not only incidence. The mortality of cancer is rising, and it's going to be the number 1 cause, surpassing ischemic heart disease, stroke, and all infections are going to go down. And again, this is WHO prediction. So you have an epidemic with an increasing incidence and an increasing mortality. But what's most disheartening is that when you look at incidence to mortality in the developed world, it is 0.3, 0.4. That means for every 3 diagnoses that they make, only 1 person will succumb of the cancer. But look at India. Out of every 3 diagnoses that we make, 2 will succumb of the cancer. So the number of people dying in our country is double. And unfortunately, 2/3 of these deaths are before the age of 70. That's the most productive years of someone's life when they should be contributing to the growth and economy of our country. So we are going to have an increased mortality and increased incidence, and we are going to lose our patients prematurely much before their age of 70. Many of you all will recognize these 2 photographs. The person to the left of the screen is Richard Nixon. He was the president of the USA. In 1971, he did what's known as the National Cancer Act, where it was a Time magazine cover story. Those of you all who remember, he said we will conquer cancer. In 2016, the then Vice President Joe Biden, who is now President of the US, renewed his war on cancer when his son died of a brain tumor. Joe Biden. In 40 years, cancer was not conquered. It still remained the cause of death. In the US, and this was when Joe Biden started his moonshot program, 1,650 people every day were diagnosed with cancer. And 16 lakh new cancer cases were diagnosed annually. In our country, the figure today is 11 lakhs. It used to be 10 lakhs 2-3 years back. It's 11 lakhs now. So with these dismal figures and rising incidence, increased mortality, more people dying, the war against cancer is not won. How do we outsmart this problem as physicians? And I've broken this up into 3 points. Can we prevent cancer occurring? How do we detect cancer early? And how do we ensure proper treatment for our patients? So we are first going to see whether we can prevent cancer. Cancer is preventable in 2/3 of our patients. It's a lifestyle disease. And the most important lifestyle factor is tobacco. 40% of our cancers in our country are tobacco related. And head and neck, which I practice, is 27 to 30% of all our cancers. Again, this is WHO Globocan map. The dark blue show you where tobacco cancers are the highest. And if you look at our country, it's the highest amongst all countries. That's why head and neck is very, very common. Oral cancer is very, very common. And that's because tobacco is a socially accepted custom in our country. It's everywhere. If someone has a drink, we think it's a taboo in our country. But if someone eats a pudiya of tobacco or eats supari, we think it's normal, it's social. We welcome our guests with these kind of things at weddings. After a good dinner, we go out. This little kiosk, which is the pawn shop, is taken between 2 chemists opposite the Tata Memorial Hospital, which is a premier cancer hospital of the country. Just to tell you that it is socially accepted in our country. And if you look at GATS, which is Global Adult Tobacco Survey data, 266.8 million of our countrymen take cancer. Focus on the boxes to the extreme left of the screen and the tallest star. Tobacco users are 42.4% of our country. So nearly half our country is using tobacco. People even in the age group of 13 to 15, 20% of kids use tobacco. And second-hand smoke, that means I'm smoking, you are inhaling. Above the age of 15, 30% of people. And that's why we have such a high and rising incidence of cancer. It's important to know that cancer in our country is consumed in 2 forms, smokeless and smoke. Generally, all the public health policies are for smoked tobacco. But if you look at smokeless tobacco, the number of people is very high. But it's very difficult to give up smokeless tobacco. So these are the number of people, again from the GAD survey, who are trying to attempt to give away tobacco. And you can see that the success rate, and this is the extreme right-hand corner of your panel this side, former daily smokeless tobaccos, the number who can give up is 5.8. But smokers at 16.8%. So I think we need to direct our efforts on patients or on population who are smokeless tobaccos. And because we take smokeless tobacco, we have a higher incidence of oral cavity cancer in our country. And here is head and neck, which is my specialty. You can see that 50% of the global data is from Asia, and you can again see India as a bright blue spot with 1/3 of all cancers in the head and neck field. So the first prevention is to get people to stop tobacco. The second, and many of you all will be surprised with this, 10% of cancers in our country are obesity related. If you're overweight, you'll have a higher incidence of cancer. You have a cancer of the esophagus, gallbladder, kidney, colorectal, particularly in women, post-menopausal breast cancer, pancreatic and endometrial cancer if you're overweight. We always believe malnutrition was bad, but for cancer, if you're overweight, it's a higher risk that you have cancer. For malnutrition, many of us in our practice write multivitamins to our patients. Now I put up 3 studies which are little old but close to 20,000 patients in each. They gave various forms of multivitamins. Beta carotene, you'll remember, is a pro-vitamin A. Retinol, vitamin A, alpha tocopherol, vitamin E. When you look at the bottom line, giving these multivitamins in an artificial form has no effect, or in some studies is detrimental. So again, those in general practice, if you're giving routine multivitamins to prevent against cancer, it may not be the best thing to do. You must encourage your patients to stop their habit and have a good diet, and that will increase or decrease the incidence of cancer. And the third preventable cause of cancer is infections. And there are 5 infections that really cause the majority of cancer. Helicobacter pylori, which causes stomach cancer. Human papilloma virus, which causes cervical cancer in women. The Epstein-Barr virus, which we see in the northeast of our country, which causes nasopharynx. So if you have someone from the northeast, stuffiness of the nose, you have to suspect a nasopharynx cancer. And hepatitis B and C. Again, absolutely preventable. You can either treat it or you can vaccinate your patients. And again, for those of you all in practice, WHO has given a call to prevent against human papilloma virus, and we now advocate inoculating all young girls before the first sexual intercourse with 3 doses of a multivariate Gardasil vaccine, which prevents against cervical cancer. Cervical cancer used to be the #1 cancer killer in women in our country. Now it's surpassed by breast cancer, but it is still a significant. Half the world's cervical cancer comes from our country. So I've told you how to prevent cancer: habits, infection, and proper diet. Let's go to the next point as to whether before I go, I just want to quickly summarize. 40% of cancers are tobacco, alcohol related, 10% are due to obesity, and 10% due to infections. And if you can control just a change in your lifestyle, about 50 to 60% of cancers will not be there. And it's not only cancers, you'll also prevent against non-communicable diseases. So I put this slide up, it's called 4480. 4 modifiable shared risk factors affect 4 major NCDs, and they are responsible for 80% of NCDs, which is non-communicable diseases. So the 4 modifiable risk factors are tobacco, an unhealthy diet, lack of physical activity, and the harmful effects of tobacco. And you can see that they affect cardiovascular, type 2 diabetes, cancer, and chronic respiratory diseases. So if we modify our lifestyle, we would help in the prevention of 4 NCDs and not cancer alone. From prevention, we move to how we can detect these cancers early. Please remember, if a cancer is detected in stage 1, 90% cure rate, simple treatment, and they don't need continuous treatment like diabetes and hypertension for the rest of their life. We see cancers like this. I'm sorry to put up these frightening photographs, but this is the state in our country. 70 to 80% of our countrymen come with advanced diagnosis across 9 Asian countries. I've only taken breast cancer as an example. You can see that our 5-year survival is 52% compared to 82% in China. And this has other countries as well. Pakistan, Philippines, Saudi, Singapore, South Korea. So it's again because of late diagnosis. And I think all of us as physicians play a very, very important role. So I did a little study at 2 time points in my career to find out why patients come late. There are various reasons, socio-economic, but I've just highlighted one in red. Among patients who go to their doctor, 50% of the time, it's lack of the general physician diagnosing the disease and referring to a specialist, and it results in a 7 months wait before the patient comes to a specialist. I'll just give you one example. It's a patient who comes with a lymph node in the neck. Very often we empirically treat our patient with anti-tuberculous treatment. You have a patient with a cough and a patch in the lung. Very often we treat empirically with anti-tuberculous. It could be cancer. So if it's a smoker, has a lymph node above the age of 40, the probability of it being cancer is upwards of 80%, not tuberculosis. If it's less than 40, then you can have inflammatory disease. So how do we know what we want to do? We can't go and screen the entire population. It's not cost effective. Majority of screening programs don't have robust evidence. So what I recommend is opportunistic or high-risk screening, which all of us should do in our practice. And here are the opportunistic patients that you should see. In your practice, if anybody's tobacco or alcohol habits, anybody with a family history of cancer, anybody who has signs and symptoms that are called caution or go by an acronym by caution, and I'll show you what that means, you must screen these patients for cancer. It's not cost effective to screen everybody who comes to your clinic for cancer. So remember the high risk habits, family history or caution. And what is caution? I put it up here. It's an acronym for 1, 2, 3, 4, 5, 6, 7 symptoms that will alert you that your patient could have a cancer. I'm not going to go through each one of these. These are from the American Cancer Society. It's a free download, and all you have to do is download it and just put it up in your clinic so that it can warn patients waiting in the waiting room as to when they should alert you that they've got a problem. Just for example, a change in bladder or bowel habits, or say tea or thickening or lump in the breast or elsewhere. Or if the patient has a nagging cough, pain, hoarseness. So I just urge you all to take a printout and investigate your patients who have these warning signs. And all tests are very simple. You don't need fancy investigations to diagnose cancer. Oral cancer, clinical examination. Lung cancer, non-contrast CT scan of the chest. GI cancer, just a stool occult blood. Prostate cancer, if you don't want to do a digital examination, an ultrasound or a PSA. Breast, a mammogram, breast self-examination, clinical examination. Cervix, a pap smear. And leukemias, all you have to do is a CBC and a smear. All these tests less than 1,000 rupees. So remember caution, remember the simple tests that you want to do. And you'll be able to get patients into stage 1 and 2 where we have upwards of 90% cure rate. I'm moving to the third and last part of the talk. Unfortunately, despite prevention, early diagnosis, some of our patients will have cancer. How do we ensure that they have the right treatment? We know that in our country and in most countries there's inequalities in treatment. Here's a morphed figure of the globe. Areas that have the highest population, that's panel A, have the highest burden of disease, that's panel B. They have few medical schools or qualified personnel, panel C, and the workforce is also very limited. And that's the problem in our country. Yet as physicians, we can direct our patients to proper care. Again, if you know, there's a big divide in cancer treatment. I put up two panels from a very interesting article and book that looks at outcomes in developed world and in developing world. Children cancer to the left, where 80% of children should be cured, and you can see that the mortality is much lower in high-income countries compared to low-income countries. And I put up 6 adult cancers which should be near 100% curable. Cervix, breast, testes, prostate, Hodgkin's lymphoma, non-Hodgkin's. And look at the mortality in low-income countries, it's right on top compared to high-income countries. So what can we do to help our patients? We have great treatment. I'm not going to spend time showing you all videos on this. We have very, very good advances. And there are many good centers today that offer it both in corporate world and in government. Surgery, advanced radiotherapy, multi-drug chemotherapy, and good imaging to diagnose your patients correctly. We must see that we not only give the best care for our patients, but we strengthen the primary health care in our country. And we need a combination of early diagnosis with high-end care. If you send a patient to me at Apollo with stage 4, whatever much I do, my survival will still be 40 to 50%. So we need to diagnose our patients early. We must send our patients to high volume centers and those that do specialized practice. And I say this not because of myself, but also because of level 1 evidence published in the New England Journal of Medicine, looking in centers in the US where community care is very good, that hospital and surgeon volume affect outcomes. So you must choose the right referral doctor for your patient. And lastly, you must do practice where doctors adhere to evidence-based guidelines. And here again is a study that I did when I was in the Tata Memorial Hospital, 1,500 patients, that we see that the adherence to guidelines was better in specialty centers as compared to those in community-based practice. So whenever you choose your referral, it should be to people who do specialty niche care practice which has evidence base. I'm ending with my take-home message. Cancer is a global problem with an increased burden in the developing countries. There's gross disparities in outcome between us and the West. Our focus should be on prevention and early detection, and we must search for cost-effective cures which can improve the plight of our patients. I thank you all once again for the opportunity to be here.
Dr. Dcruz, you can come here. we'll have question answers at the end of both the talks. So next talk is by Dr. Sudheer Tyagi. He is a very senior neurosurgeon. He is in Indraprastha Apollo Hospital for last 25 years. He is a graduate of King George Medical College, Lucknow, and then he did MCH neurosurgery from All India Institute, New Delhi. He has done skull-based neurovascular surgery training from Slovenia and functional neurosurgery training from Sydney, Australia. He is one of the pioneers who performed first DBS surgery in India using image fusion technique in 2000. He has a number of publications and he has written in many textbooks of operative neurosurgery, and also he has trained many neurosurgeons under DMD programs in Apollo Hospital. So Dr. Sudheer Tyagi will speak on DBS in Parkinson disease. I please welcome Dr. Tyagi with a big round of applause. Dr. Tyagi, please.
Thank you so much for inviting us and sharing our experience. The topic which I have chosen is the interest of physician as well as the surgeons. The topic is deep brain stimulation surgery in Parkinson's disease. Parkinson's disease is basically treated initially by general physician, and after that neurophysicians. The surgical work comes very late, and it is in very well chosen patients only. And we operate the patients of the Parkinson's disease only when they are properly referred and evaluated by the physicians and the neurophysicians, and they have taken the proper medical treatment earlier. So these are the different osteotactic frames in which we put over the head of the patient's head and calculate the target inside the brain, especially some nucleus. Nucleus is basically a group of neurons, and that nucleus is targeted through these frames. The deep brain stimulation surgery is basically high frequency stimulation induces the functional inhibition of the target region of the brain of a particular nucleus and choose the nucleus according to the disease. If we have the Parkinson's disease, the target will be different. If the is an essential tremor, the target will be different. If the patient is having OCD, the target will be totally different. So we select the particular group of neurons, the nucleus, the target, according to the disease and the indication. There are different patients which I have treated. I have treated the patient with essential tremors. The maximum cases I have operated are of advanced Parkinson's disease, and this is the first case I did in year 2000. Though it was approved by FDA in 2002, but we started doing the surgery in year 2000 before that. Dystonia, epilepsy, psychiatric disorder, especially OCD, and chronic pain. These are the different indications. I have done in Parkinson, essential tremor, dystonias, and cases of the intracranial epilepsy treated by the deep brain stimulation. The patient selection criteria is very, very rigid. The patient should have idiopathic Parkinson's disease with a good levodopa response. All the physicians know that levodopa is one of the best drugs, which is a kind of a revolution in the treatment of the Parkinson's disease. The patient who responds to the levodopa also responds well to the deep brain stimulation as well. The patient should be medically and psychologically stable, and he should have a severe disease. We are not operating the mild and moderate disease patients. We are operating on the patients who are having severe Parkinson illness. PD medication should be ineffective and has been treated the patient for quite some time by the neurophysician. And the neurophysician is the right person who evaluates the patient and says the medicines are no more effective now. This patient should go to for the deep brain stimulation surgery. Age is no bar. I have treated the patient from the age of 30 years up to the 75 years of age. If the patient is medically stable, can be treated with the surgery. There are certain important exclusion criteria where we don't take those patients who have any patient who is not a good candidate for surgery, medically is not fit, we don't take those patients. Previous neurosurgical history, if the patient already had head injury or brain tumor surgery or neurovascular surgery, they are not good patients for the surgical treatment of the Parkinson's disease. Repeated MRI. Earlier, we were not used to do MRI after the deep brain stimulation. Any patients who are used to require repeated MRI with other illnesses like a spine problem or other brain problem, those patients will not do well because every time we do the MRI, the configuration of the stimulation will change. Patients with secondary or drug-induced Parkinsonism are not good candidates for the deep brain stimulation surgery. Every patient is evaluated by the neurophysician on UPDRS scale, and the patients who are having the grade 4 and grade 5 on the UPDRS scale, only those patients we take for the surgical treatment. The other different cases, actually it's a whole slide. I have done about 165 cases till now, and out of them maximum number is of the Parkinson's disease. These are the different target sites which I was talking, like for the Parkinson's disease especially, I used to stimulate the subthalamic nucleus because it improves the tremor, rigidity and the postural instability along with the kinesia. A patient who is having predominantly tremors, then the GPI, the globus pallidus internus, is a good target for them. Any patient who has only tremors and the essential tremor and the PB tremors, then we do the VIM, ventral intermediate nucleus of the thalamus, is the right target for them. Different technique has been used by different neurosurgeons while they are trying to do the histotactic work for the function neurosurgery, like just MRI based histotaxy, MRI in the anterior commissure and the posterior commissure line, CT scan and the MRI and then their fusion. Then CT scan, MRI and fusion with the neuroatlas. The CT MRI with fusion and MER localization is a micro electrode recording during the surgery. When I initially started in year 2000, I was used to do the CT scan, MRI fusion, and then used to use the neuroatlas along with MER. So I was using 4 things to localize my target. The target size is only 7 to 8 millimeter in the deep part of the brain. If my microelectrode is not reaching right up to that nucleus of that particular group of the neurons, the deep brain stimulation will not work. So I was to take all the 4 things, microelectrode recording during the surgery, and the CT scan, MRI, and fused images, and used to see my target with the neuroatlas. So I was not giving anything so that I don't make any mistake, because I was also one of the learner at that time. I was just beginner. But now I do the CT scan with the putting the frame, and a day before I do the MRI, and after doing the CT scan, the MRI, I will take the advantage of both the images, CT scan and the MRI, because the neuroanatomical definition is much better on the MRI than the nucleus, but bony landmarks are better seen on the CT scan. So I take the advantage of both the modalities, and then I do the image fusion by using the Chamfer's principle. We fuse both the images. I will not go to the details because it is technical. But the images look like this after the fusion, CT scan and the MRI. And then I localize the nucleus on these fused images. And after this, seeing this, I see on the master computer, on the AC line and the PC line, you can see this is the anterior commissure, this is the posterior commissure. And on this fused image, we go lateral and go down. And it's very close to the brainstem. The nucleus is just above the red nucleus, in the brainstem. Just lateral to that is the subthalamic nucleus. And after localizing, I see the target on the neuroatlas, which is already built in my computer. So when I put the target XY coordinate, it will show me where I am actually. This is the actually subthalamic nucleus, where I can see my target is right inside the subthalamic nucleus. That's how this microelectrode looks like when I have implanted them into the brain. It's a very quite deep inside the brain. And this is the lead, this is a microelectrode, and this is all connection going up to here. And from here it goes down to the with a wire and connected to the subtype with this pacemaker kind, neurological pacemaker called IPG. So this is the whole assembly. These are the different part of the programmer and the different part of the deep brain stimulation which we use. Right now we can do the programming, remote programming also through the net. Patient is at his house and I am in the hospital, they can connect with me and I can change his stimulation parameters, voltage, milliamperes and the pulse width while I'm sitting in my room in my OPD. So this is also now possible. Earlier we used to call the patient initially for every 1 month or 3 months and later on for every year. Now we are not doing that. So we can do it through the net. This is one of the patients in which I have already put this plate, and after this we do the CT scan and choose the image of the MRI. That's how it looks like. We make a burr hole, put a cap over the skull, and from here to this frame, we put the XY coordinate which we have already calculated on the frame and go inside the brain. This is one of the patients as is going on. And the patient is under local anesthesia. We give the patient to choice whether he wants the surgery under local anesthesia or under general anesthesia. This particular patient is under local anesthesia. The whole data is in front of me, which I carry in the operation theatre. And after putting the microelectrode into the particular nucleus, we stimulate it and see during the surgery how much it is working, and we call our neurophysician beside the operation theatre so that he can assess without any bias clinically the patient is really improving when I am stimulating the target. And after that I do the permanent implantation. This is the patient. We are seeing the rigidity and the final movements we are checking. This is our neurophysician who is checking it. So after checking this, when we are satisfied the patient is really doing well on the stimulation, we do the permanent implantation. This is microelectrode recording. When I reach inside the nucleus, we do this recording to check whether I am really inside the nucleus or outside the nucleus. So when I reach inside the nucleus, I find these biphasic waves. Moment I go out, the wave will change like this. It will change into like this. It will be proper biphasic waves. So I can really actually map by the microelectrode recording when I am entering the nucleus or when I am going out of the nucleus. In that particular millimeters, I have to put the microelectrode. And on the C arm during the surgery, the microelectrode looks like this. And you see there are the 4 parts in each. So sometimes if I am in the, while I am putting the microelectrode, if 1 or 2 minutes I am outside or inside, being these different parts, I can instrument this part, this part, this part, according to my choice and according to the what the patient is getting the best response on which part of the stimulator. And that's how after the permanent implantation, we put the over the skull cap and fix it. This is an IPG pacemaker which is connected to the brain microelectrode, and it will be put into the subclavicular area, subcutaneous. This is one of the patients who had tremor-dominant Parkinson, especially hemi-Parkinson. It was only on the left side. This patient has been treated from the very young age. For about 20 years he has taken medicine, but now medicine has stopped working. He's been to different countries, different people, treated by different neurophysicians. Then finally he came. He actually advised DBS in Germany, but he was finding it very expensive there. So he came to India, and I operated upon him. So I have put the only contralateral nuclear stimulation in this patient. Subthalamic nucleus implantation was done 4 days back, and this is 5th post-op day. So right now it is off. We switch it on. The moment we switch it, within 30 or 40 seconds, it will start working after the stimulation. So this is a very funny kind of tremors which stop completely, not responding to any medicine.
Wonderful.
Beautiful.
You can check the fine movements, rigidity, tremor, everything we check. So this was year 2006. I'm looking little younger.
Absolutely.
This is another patient. He's a retired army officer who had the complete triad of the symptoms of the Parkinson's disease, like rigidity, tremors, echinacea, along with this posture instability and freezing, with trophic changes in his toes because of inactivity. So he's been treated by different neurophysicians, especially in the R&R, and finally he stopped responding to the medicine. So he came to me. Actually, he was advised deep stimulation surgery in R&R hospital, but facility was not there, so he was referred to me. And then I operated upon him. I have done the bilateral implantation. The condition was such that if he freeze here, he will not move. And his son used to be here with him all the time, one of his sons, to take him to the washroom and every places. He was accompanied. This is after about 1 month of the surgery. Same patient. I have done the 3 times I did the programming to get the best optimal result, best of the parameters to stimulate the bilateral subthalamic. And then we see the response.
Wonderful.
We should see how he walks now. We have to make him walk. We are just checking the coordinated movements.
Great achievement.
So he's back to his life. Sometimes I get very funny patients where the diagnosis is also very difficult. He had a very different kind of tremors, neither totally pinballing nor totally like essential tremors, but all the time he had these tremors bilateral. No other problem, but his social life was very bad because of it. He used to feel ashamed going anywhere. So I did the bilateral stimulation, implanted deep brain stimulation, and now we are just going to start it and see. After about 30-40 seconds, you will get a complete response.
This is not PD.
This is finally diagnosed as a PD. When 2 neurophysicians who are involved in this, they diagnosed it finally as a PD. But it was not a classical diagnosis. This is how it stops. So these are little things, subthalamic stimulation outcome is actually very good in all the parts. If you see the dyskinesia patients who have the syndrome dyskinesia, they do very well. Patients have good on time and the sleep time is good. Where the efficacy, benefits of DBS therapy, the impact is phenomenal in the life of the patients. The average improvement in the on time is about 6 hours, increased by the 6 hours of the DBS. The long-term efficacy is very well proven in the DBS. The battery which was we put initially was for 5 years, and after 5 years we have to change the circular part of the battery, not the radial part. Now the batteries are coming which work for about 15 years and maybe more now. So all that tremor, bradykinesia, axial symptoms, speech, gait, posture, there are evidence that everything improves significantly. The deep brain stimulation and the outcome are very, very good statistically. I would like to speak, rather than these things, I would like to speak about some complications. People might be interested. What are the complications in these surgeries?
Sir, could you summarize it faster so that we can have some time for discussion?
Discussion, sir.
So I'm just coming to the last.
Last night.
Mainly the schizophrenia symptom usually come.
Huh?
Schizophrenia symptom usually they label them on anti-Parkinson.
We'll discuss it later. Just let me complete. Otherwise,
Let's finish it, sir.
Question answer.
Question answer.
the complications The completion rate is about 1%, which includes infection, bleeding in the brain. Because we are going inside the deep part of the brain, on both the sides, so chances of having hemorrhage during the surgery about 1%. Out of all my cases, I had one patient which I was doing under local anesthesia. He had thyroid bleed during the surgery and he stopped responding in between. So I had to stop and we just did not do the surgery further. But the patient luckily improved with time and later on we did the implantation on one side. So these are the usual problems. Sometimes the problem in the leads and the people have some fracture in the lead, but they are all outside that can be changed without going inside the brain. Thank you very much for the patience.
Thank you, Dr. You can join here.
Yeah.
Light, please, light.
So, Dr. Ameesh has to go, so we'll have some questions first for conversation. I will first give mic to Dr. Ameesh for his comment, then we'll ask for the question from the audience. For your
Thank you, sir. I think what Dr. Dcruz sir highlighted is an understatement. Cancer is a pandemic and a bigger pandemic than COVID. The number of lives we have lost in cancer cases which are preventable is beyond comprehension. And I thank sir for highlighting the need and what are the remedies which can be done to decrease the incidence and increase the cure. So before I throw open the questions to the audience, as a moderator, sir, I have the first prerogative to ask the question. Sir, from the forum, I would like to ask you, we hear a lot about robotic surgeries nowadays, and we also hear about organ preservation. For example, Parashar sir यहाँ पे है, commando surgery means mandible loss. But Dr. Devendra Chowkar and sir's team from Tata Hospital have recently done a study where you can preserve mandible in 50% of patients. So would like to throw lights on these two aspects.
So, Ameesh, your point is very well taken. When I studied, we believed in cancer, you have to cut more. Jitna nikaloge, utna cure rate badhegi. But that concept has changed. We have shifted. If you ask what was the major advance, 2 decades back, it was organ preservation. It's not only in mandible, it's all over the body. In Pilgrim's time, they removed the breast of a lady. When I trained, we removed the breast of a lady. Today, 80% of ladies, we save the breast. You look at colon rectum. We used to remove the rectum in all patients. Today we say, same in head and neck. So it is organ preservation. We have to look at the biology. And again, an appeal I made to all of you all that if we get patients in early stage, we can save the organ. We can increase cure rates. We can decrease toxicity of treatment. Then they only need single modality therapy. And costs, everything is better for the patient. So again, a plea, early detection, save lives, save organs. Robotic surgery is good. It's new. It's used mainly in the coelomic cavity, the abdomen and in the thorax. We use it minimally in head and neck for thyroid, and we use it sometimes for oropharyngeal cancers. But thyroid, we are slowly shifting away from robotic, because to do robotic, we have to come in through the breast or the axilla. And if you avoid a scar here, it comes again in sensitive places of the body. So slowly we are trying to evolve what is known as transoral resection of thyroid. Unfortunately, it's only suitable for thyroids which are small volume, less than 3 centimeters. For large conventional surgery still. So robotic is there, very important in urology. It's absolutely not replaceable in parts of GI surgery, in gynec surgery, and to some extent in thoracic surgery as well.
Thank you, sir. Now, little controversial and last question from my side. This is a question which, whenever I talk of immunotherapy, all of you know that the two scientists got the Nobel Prize for Physiology who discovered immunotherapy. And those who have reading Times of India have seen in rectal cancer, localized disease, where only surgery and radiation was the norm. The immunotherapy injection has changed the way we look at it. It may be too early, but sir, a medical oncologist asking the question to a surgical oncologist, is immunotherapy going to replace the standard surgeries in future or second generation, third generation drugs?
I guess too premature to make that conclusion. In this series that you are describing, wonderful results, small group of patients. But having said that, just a dictum to everybody, solid tumors which are not liquid, which are not blood or lymphoma, chemotherapy जड़ से नष्ट कभी नहीं करेगी बीमारी. You have to have surgery or radiotherapy to help. And I made a point when I started, multidisciplinary care. So if we work together, we will honge kamyab. So that's what. So you cannot replace us, but we will work together, save more rectum, save more.
I think that's good. But in oncology, oncosurgeons, medical oncologists and radiotherapists, they all work in tandem. So I think Dr. Ameesh, also you have to go for an emergency. You can go. Anybody, Dr. Tulsi, he is very eager to ask questions. Dr. Tulsi.
I really am very eager to ask questions. Dr. Ameesh, wonderful, and Dr. Dcruz as well. Friends, 1 in a million. Dr. Dcruz, who has changed lives of not only doctors, also patients.
Yes.
1 in a million. Let's have a. It was very nice interacting with you, Dr. Dcruz, and I believe you are here at least twice a month to look after our patients. So, Dr. Ameesh, you talked about advanced cancer that significantly has improved now, not only in medical oncology, surgical oncology, and in medical oncology as well. So, an era of precision medicine, see, early detection, as Dr. Dcruz said, and you too said, and whether you have rapid access to the latest treatment is so important. So, are we there now? Dr. Ameesh.
I would, why I was instigating Dr. Dcruz sir is, even in medical oncology, his knowledge is very profound. So I would like to ask him about the precision oncology in cancer. Where have we reached? That is a question what you are asking, right?
I thought it was surgical oncology.
Sir, his knowledge is profound.
You answer.
Okay, sir, so...
That's why I said 1 million.
I'll tell you, sir, we are moving fast forward. As Dr. Dcruz, sir, we are still not there, but we are moving very fast forward. Right now, 20% of the scenario is about to change drastically. I'm not saying it has changed, but about to change drastically in next 3 to 4 years. As I told you, sir, rectal cancer, localized disease, getting cured only with immunotherapy was unheard of in my lifetime, but just 16 patients. When that goes up to 160 patients, 1,600 patients, only then we would be able to tell. But today, and Dcruz sir may agree, leukoplakia, the precancerous lesion in mouth, in this ESMO, European Society of Medical Oncology, they said in leukoplakia, if you give precision oncology drug, immunotherapy, 60% of leukoplakia reverses. Again, a small study, but you know, the way John F. Kennedy had told that a small step on the moon, but a giant leap for the mankind. I think that is where we are heading. So,
I would agree. It's all in evolution, but this precision medicine will change. So again, when I was a student, lung cancer, if you couldn't operate, all patients would die in 6 to 9 months. Today we take a bit of tumor, we run it through some mutations, EGFR, ALK, various other types of mutations. See an actionable mutation which a target can work on. We now push survival to 3.5, 4, maybe sometimes even a little beyond, but an average of 3.5 to 4 years before 6 months. From 4 years, after a couple of years, we'll go to 5, 6, 7, it will become like non-communicable diseases. Like you pop a diabetic pill and your diabetes is controlled for the rest of your life. We'll slowly transition into that, and that's with actionable mutations that we'll see in tumors.
So, Dr. Cruz, further to my questions to you, so JAMA Oncology, just about a week back, Arbuda, talked about the differences in cancer phenotypes amongst frequent check 2 variants and the implications for clinical care, checking check 2. See, probably would differentiate between pathogenic variants associated with different cancer phenotypes. So, just published about a week back, Dr. Ameesh is having a smile. So probably either of you two like to ask about that or answer about that?
Go ahead,
Sir, you have opened up
Pandora's box.
not even Pandora's box. I can't tell you, what you are talking about is a process called NGS, next generation sequencing. There is a DNA sequencing, there is RNA sequencing, out of which we medical oncologists understand 0.0001% of them. Okay? Check 2 point mutation a few years back was VUS, variation of unknown significance. We didn't know what to do with that. Mutation is there, क्या करने का पता नहीं. Today, check 2 mutation has become a pathogenic variant. Okay? So, similarly with PALB2, BRCA1, BRCA2 सबको पता है, but remaining 30 genes nobody knows. So that is where we are reaching. The JAMA Oncology, the person who must have written this article, himself, if you ask him what is RNA sequencing, he would not know. The reason is not that he is not knowledgeable. We are evolving, sir.
We are evolving.
That is the bottom.
That is the bottom line. So, Dr. Dcruz and also Dr. Ameesh, so nipple sparing mastectomies with pre-pectoral reconstructions. Is this the modality what you are doing now? You talk little about the nipple. Just talk us through that.
So basically in all breast cancers, if they come early, we can do what's known as breast conservative surgery. Nipple sparing, it will be spared if it's in the lateral quadrants of the breast. So they divide the breast into 5 quadrants, 2 medial, 2 lateral and central. In the 4 you will be able to spare the nipple. In a central quadrant, it's a problem. And now, even with slightly bigger tumors, we are able to give chemotherapy, shrink the tumor and bring them into the realm of breast conservation surgery. So yes, breast conservation surgery is the norm. In some cases, in central quadrant, we are able to do nipple sparing.
Specifically, probably what Dr. Dcruz is saying, if the tumor is T2, suppose, and if you give pre-operative chemotherapy or adjuvant chemotherapy, you can downgrade the tumor to T1 and you can do breast conservation.
So, Dr. Poddar, which is the most commonest quadrant where you get the breast CA?
I don't want, it's the outer upper quadrant.
Wonderful, sir.
But let me also ask you a question: which breast is more common, sir?
Left.
Right or left?
Left.
Sir, no.
Left.
Yeah.
People are right-handed.
Any scientific basis for that?
No, it's a naughty answer which I tell you like the bar later.
So, after that naughty answer, probably, I think Ameesh has to leave, probably they can, you would like to answer questions?
I will answer the question.
Ask some questions.
Yeah, I will answer the question. Yeah, इनका एक बैग एक्स्ट्रा हो गया anyway. Sir, it was mesmerizing talk, sir. Dr. Ameesh had also heard about you. My few questions, sir. MRM, radical mastectomy, and reconstruction of the breast at the same sitting. How common it is done and how advisable it is.
This is a very frequently asked question.
That really dip is possible. It can be done frequently. It depends on the demands and expectation of the lady. So if the lady has a cancer that needs an MRM, this is my personal opinion, and chemo, radio take precedence over reconstruction, we must save life. So in that case, I may not advise. But if the lady has high expectation, it's individual to each lady. You can do it. And the commonest reconstruction that is normally done. So breast oncoplasty is of various types. So the type 1 is just mobilizing the local breast tissue and filling the gap and doing it. And then it's bringing tissue from outside either to do partial augmentation or replace the entire breast. And we normally do latissimus dorsi, or we do what is known as a tram flap. The rectus abdominis free flap that gives the mount, and then subsequently tattooing to create the nipple and the areola.
So nowadays breast oncoplasty is very common.
Very
You don't take latissimus dorsi flap or rectus abdominis flap.
Absolutely.
You can do just by local.
But that again, early detection, amenable.
It maybe only in state.
Sir, my questions are still on. Vegetarian diet versus non-vegetarian diet in terms of causation of cancer, which is more related to cancer as preventive as all.
Colon cancer is very common among people who take a non-vegetarian diet in the West because of the fats in the meat. Plus you take a low roughage. Videsh jaoge, they'll eat a beef steak or a steak and they'll only eat so many vegetables and small rice. So the transit